Joe at the microphone already. So ready to start? Yeah? Good.
Hi. You mentioned, Frank, children as one of the groups to look at. But in a previous slide, you also said we need very clear-cut endpoints as to TB disease. And I think those are true and difficult.
Yes, that's absolutely true. Especially, well, I think there's. I was already thinking in terms of sensitivity and specificity, but I think you have problems on both sides, on both ends, with regard to diagnosis in children. So that's absolutely true. So that's a limitation of. And I think most people would probably agree that you need to know what these tests will do in children, but at the same time, it's more difficult to evaluate. So thank you for that comment.
Hi, it's Aditya Kadamanchi from UCSF. So Frank, thanks for the really nice talk. I think one of the reasons that the types of studies that you've mentioned haven't been done is not just because they haven't been thought of, but just because they're really expensive to do and difficult to do. So I think another thing that might be useful is think about how do we decide which test to advance to those types of trials. And so do you have any thoughts about sort of how we make those, what are the preliminary studies that need to be done to say, okay, this is a test or a candidate that's ready for us to invest the kind of effort and money that's needed to do the types of studies that you're talking about. And I'm not sure that I really sort of get a sense of how we're going to make those decisions in a way that sort of helps kind of move forward in an effective way for funding.
Yeah, that's a great point, Aditya. And I so we didn't go into detail on the analytical phase, but of course that's the sort of selection. There's a sort of selection step after that. So I think that if you would, so in the analytical phase, you would primarily look at banked samples, and ideally you would use banked samples of people who in the end got tuberculosis, and that will tell you what the sort of how promising that particular test could be if you bring it into the clinical phase. I think that would be the most important selection step, because the other things, the other designs that I mentioned are, I think, are really also in this stage non-informative, because they probably tell us about such tests as a reflection of recent exposure, but that's not really what we're looking for.
Yeah, I agree. Just to add to that, I guess another way to approach this, another area that we have to focus on, I think, is specimen collection in that area. And there's, it's because of the long time it takes to recruit patients and for the follow-up period, if we want to evaluate tests in a reasonable amount of time, that will be, I think, absolutely crucial. And I think one of the advantages of the RNA-based tests that, like the correlate of risk, is that there is potential, I think, to also as part of the specimen collection to do RNA sequencing on all the specimens and essentially have the ability to do an acyclical analysis first of anything that is being proposed before using valuable specimens. Of course, doing specimen collection is just as hard as doing the study, but I guess having a concerted effort to do that would be another way of trying to tackle that problem.
Alex Betts, Logic. The study design was absolutely gorgeous, and I can see it, and it's fantastic. But on a pragmatic level, I mean, you said the burden of proof incredibly high compared to what's available at the moment. So can you see that can you foresee a stepwise approach rather than to go for the end target? Because otherwise, I mean, who's going to fund this? It will be immensely expensive, a study like that.
You mean in terms of which specific study do you? Well,
the last route to a test you described. I mean, it will require a huge amount of patience, and secondly, it will take also a long time to get to there because the follow-up over 18 months on all those patients will be immense.
Yes, but I mean, historically there have been a number of studies done that actually did that, and there have been pretty large studies of preventive treatment. So I don't think it's unfeasible. I mean, of course, I mean, but it's not necessarily terribly expensive. If you were just if you do it in the clinical phase, a cohort follow-up study, you could actually, even because you don't intervene, so you could actually combine different tests in one study, and you could do one test in that study, and as Samuel just pointed out, biobank the samples and use them for other tests, because you will have basically you have a sort of infrastructure in which you know at the end what the TB status will be. So I don't think it would be terribly expensive. It would be terribly expensive if one particular test manufacturer should be the one that has to put all the money in it. But I think this should be a concerted effort. And of course it has been, historically it's been very difficult for the sort of classical research funders to invest in infrastructure, because to some extent it's infrastructure, because you to some extent, as also what you are proposing, is biobanking actually means that you don't have an immediate outcome that you can put in your proposal. That's always a problem. But I think we are seeing some sort of positive signs here that funders are interested in doing this kind of infrastructural investment.
And maybe also just to add to that again, I guess, and that's something that Frank had also already pointed out, modeling is obviously also one way to answer the questions that Frank has posed for the phase 3, and that will never completely replace empirical studies, of course, but I think it's certainly something that will be very important to look at, in particular also since the effects may vary by context, and that's something that can be explored more easily, at least at an initial stage, through modeling.
Question from Ghana. This goes to our colleague from FIND, that the potential test for the incipient TB, we need to repeat the test in order to increase the positive predictive value. For TST, we know you need to wait for about 6 weeks. So for such a test, when do you repeat? Immediately or after some time, and when?
Yeah, that's an excellent question. I think it's not entirely clear that tests will need to be repeated. I think that will also depend perhaps a bit on the population being tested and targeted for testing and treating. And also it will depend on a lot of factors. It's a good and very difficult question. I think it also obviously depends on the cost of the test, and it depends on how you see the risk-benefit profile of what the positive test means, and given the treatments that you have available, how much overtreatment you're willing to do in order to prevent one case of progressing. So I'm afraid I don't have a simple answer to your very good question, but it's certainly a very, very important implementation consideration that's not explicitly part of the TPP, but absolutely, I think, I hope there would be a discussion in the TB research community about that.
Can I add to that? So one thing you could do, so for example, in a setting of household contact investigation, the test could, for example, be done twice with maybe 6 months in between. So it's negative on the first time, you probably won't see TB within 6 months. So you could then repeat it after 6 months. Whereas in a situation of very high transmission, you could do it, for example, annually, and annually screen your population. Of course, the requirement is that it is a very simple and inexpensive test, but if you would have a test like that, that could be really open up opportunities for mass screening and testing.
Hello, Hazel Dockrell from the London School of Hygiene and Tropical Medicine. I'd like to thank you for what you're doing, developing profiles for these tests and really focusing attention on what they might be useful for, because I think that's really critical at this point. What I'd like to make a plea for is even greater overlap with the biomarker community, because there is now quite a large community of people who are developing these signatures. And what I see is really a disconnect between people like you who are evaluating the potential use of these tests and the criteria that they'll need to fulfill, and the people then sitting in the room developing the biomarker signatures. So there are 1 or 2 overlaps, and that's great, like Tom Scriba and
in fact yourself on some occasions. But I think there is quite a large community that is now really taking the biosignatures and developing them further. They're now down to a few genes, and I think they will be even more fit for purpose. So I think it's really critical that we sort of bring those communities together and don't sit in these silos, because I think that's what we've been doing.
Okay, so that's a plea for Fine to organize a 2-day conference and bring all the biomarker people together with the test developers. I think that would be great. I think what we don't have is conferences like that actually can do this sort of work in that sense in a targeted fashion, but from a multidisciplinary point of view. So perhaps.
Yeah, I think that's a great point. I think I also have certainly the sense that they are quite separate communities working on these at the basic science level, and then in the test developer kind of implementation level later on. So thank you for that. We'll try to take that on. Thank you.
Good morning, Ken Castor, Emory University and USAID. Thank you. I really applaud the approach that you've undertaken, and a very forward-leaning approach to this to test development. One of the areas that I predict with a high probability of accuracy is problems with institutional review boards and ethical reviews, given the study design. And I think it would be wise to start having these discussions, especially in the potential target countries. I have encountered that when resource-rich countries propose research in other settings that runs counter to prevalent policies, that always raises red flags. I mean, we were involved in a study in Botswana looking at long-term therapy, and the comparison arm was 6 months, and they said, well, why would you use a comparison arm of 6 months isoniazid if in the United States our policy is to use 9 months, ideally? So questions like that are going to be raised. So we might as well predict, anticipate, and start overcoming these hurdles before we're down the path of designing the study. So I wonder if you have any additional comments, but I think that's going to be a very important consideration, and I would encourage us to start engaging in that.
Well, thanks, Ken. That's an excellent point. And that's, I mean, it's hugely important to do that, and it's also hugely important to think up front about basically the use case in the studies. I mean, there's no point in doing studies if there would, in the end, in the population where you do the studies, be no use of that particular product, be it a test or a drug. So I think these are very important things. So yes, we'll definitely follow your advice in this respect.
David.
Hi, this is David Dowdy from Johns Hopkins. Great talks, and I think what's really helpful in what you presented is helping us to crystallize what these next generation of tests for incipient TB would look like. I worry that as we get more clear in our thinking, it becomes a more pessimistic picture, because you're saying that we have to capture people within this, or arguably within this 12 to 18 month window period of incipient TB. And if we're going to do that for like mass screening, we're going to say we're only going to be able to offer preventive therapy to those who are going to develop TB in the next maybe 1 or 2 years, which still leaves a massive pool out there. If we're going to do it for contact investigation, you could argue that the probability of TB is so high that we should just give it to them without a test anyhow. And so from the perspective of trying to reduce the population level burden of TB, how do you see this factoring in, and is there a way that we can be more optimistic about the role of these tests as we think about them more clearly?
Yeah, so I think how a test like that can really be used, of course, depends on a lot of factors, and cost and simplicity and performance being some of the very important ones there. I think personally, I mean, that's really my personal view. I think realistically, I would see a test like that first being used in a setting of contact tracing rather than mass screening, but really it depends exactly how things work out in the end. And I think there, it's fair to say that we should be doing much more of that already anyways. And I think part of the reason why that's not happening is because we know that our tools are not so great, and part of it is obviously that this is not a cheap thing necessarily to do. But hopefully better tools will help people see that there's a better risk-benefit profile of doing that and better cost-effectiveness of doing that, and kind of invigorate efforts in that direction. And whether, I think it's you could always, of course, say, well, either you could just treat nobody or you could treat everybody. I think what a good test does is expand the number of, expand the window essentially of making this a useful, making it useful to treat people. So my take on that.
One immediate implication of an incipient TB test, for example, you know that there are discussions whether testing and treatment for adult contacts in high-burden countries should be pursued or not. And currently there is no recommendation, but such a test could allow that. And also there are discussions whether the 5 years for a threshold to test and treat for kids, why 5 years? Why not expanding it and increasing to 10 years or 15 years? All these would be much more feasible and acceptable with an incipient TB test, and that would be an immediate application.
So David, it's a great point. As always, I know when you come up to the, to the microphone, there's something we have to think about. So the version I gave is the glass is half full version. There is also the glass is half empty version, and that is that we won't have a test that allows us to give preventive treatment with sufficiently high predictive value to, for example, East Asia, where the big problem is an aging epidemic. So if you look at China, their problem that they will be encountering soon is an aging epidemic. So their question is, should we start treating the elderly? Because otherwise we will be looking at TB for the next 50 years. And this basically means that we won't have a test for that has sufficiently high predictive value, because we can only then look at persistent infection, and we will not be able to predict who gets TB and who won't. So that means that we should be either have a treatment regimen that's much safer, much shorter, much cheaper is not really the problem, or we should have a vaccine. So there is also a sort of negative or pessimistic view on this.
Delia Goletti from Italy. I have a comment and a question. A comment is to a question posed a few minutes ago regarding the cost. So these kind of studies will be very costly. However, I think that some of the costs can be reduced if the scientific community uses stored samples, because there are, I guess, large stored samples from the studies that have been already done, especially in South Africa. And so these studies can really help in understanding the value, the accuracy of such tests. And the question is regarding the frank presentations on the preventive treatment suggested to those that are positive to the test. So I'm wondering if you find somebody that is positive to the incipient TB test, would preventive treatment be enough? Because if the individual tested positive has, for example, is asymptomatic but has lung lesions or microbiology test positive, don't you think that preventive treatment is not enough, that you may need a full therapy? It depends on the case, but you probably may need to stratify this kind of treatments.
This is really an answer question, and we don't know. Because if you are in the stable infection situation, we know monotherapy is fine. You don't make any ARP, you don't foster resistance. Whereas if you are in the other edge of active disease, you need to give multiple therapy. With an incipient TB test, you will be in the middle of something, and my understanding would be that with no symptoms, but with other indications of the disease, you might balance towards active disease treatment, while with no symptoms, no radiological signs, no other signs, then monotherapy or treatments which are recommended for latent infection would be suitable. But we have no understanding really on that, and we have no evidence.
And I guess it'll be very interesting to see the results of the Cortes trial. I think we will really learn probably a lot from that about exactly that question: where is the border between preventive therapy and the need for multi-drug therapy? And of course, ruling out active TB is of course something that will remain key, and either that is done upfront and will hopefully help us to decide about and hopefully those that are not positive with microbiological tests will be sufficiently treated with a preventive regimen. The other way to approach that, of course, would be if an incipient TB test would not simply give an answer, is there incipient TB or nothing, but actually help us place people into one of three categories: either there's nothing, or there's incipient TB, or there's something that requires more treatment. But of course, where to draw that border will be very, very difficult without first learning more about exactly that question: when do we need more than preventive therapy? And just also to respond to your comment earlier about the specimen collection, so I absolutely agree, of course, that that's important. I think one of the challenges is that, and it depends on the biomarker that you are looking at, the type of biomarker that you're looking at. If you're looking at protein biomarkers, then I think you may perhaps be able, not an expert on that, but you may be able to use some of the stored specimens. For RNA biomarkers, I think it will be very difficult, for most of the stored specimens will not have been stored in a way to preserve the RNA, as I'm sure you also know, Delia, so that will probably be very difficult, since when we're looking into that, what is available from prior studies. But as far as I'm aware, so far not a lot has been stored in packaging tubes, and so it's going to be difficult to use that probably.
Good afternoon, Ákos Somoskövy, Global Good Fund. Thank you for the exciting presentations. Just to understand a little bit better your goals and the related potential burden. So the number needed to test is, per definition, if I'm not wrong, is the reciprocal of the absolute risk of the potential therapeutic intervention. Is that correct? I believe so. And in the routine clinical practice, an optimal number is around 2 to 5. And with routine clinical interventions with the range of 30 or higher, with interventions such as usual examples, antilipid therapy or aspirin therapy to prevent cardiac infarct or stroke, is in that range. And that was already debatable, of course, because you have to give a lifetime therapy, but you have a lifetime, of course, effect to prevent a case. This is not necessarily the situation with us. So can you help me a little better understand where would be your optimal NNT? And based on that, to a little better understand, similarly to these clinical examples, what would be the burden of intervention? And of course, this is not a lifetime protection compared to other interventions.
Thank you for that question. I think there's it's an important difference between, we are very used to the concept of a number needed to treat, and that's the reciprocal of the risk difference, as you are saying. What we're talking about here, and I didn't elaborate on that for my talk, and I would have a similar graph essentially for the number needed to test and treat. So I deliberately try to differentiate that by calling the number needed to test and treat, because it's really a different concept. It is, and that is the reciprocal of the positive predictive value. So that would be the number that you need to test and then treat according to that test result to prevent a case of progression to disease. And for that, to calculate that, it is you need to you need to also take into consideration, of course, the treatment efficacy as well as the accuracy of the test, as well as the actual underlying pretest probability, essentially. So it's not the same. It's not the same thing. I guess that's the answer to the first part of your question. And then what is optimal? I guess is of course a very, again, a difficult question, and also and I don't think one can set a threshold that is valid across across disease and treatments available. So I think it will always be a value judgment. What is the right? What is the number that we feel comfortable with? That, you know, we try to think about that based on looking what do we feel comfortable with, or what do we seem to feel comfortable with based on WHO recommendation and available tests. And you know, we are using preventive therapy, even though there's a lot of the number needed to test and treat is probably very high, 50 or 100 or more, depending on the population. And I think that implicitly shows that the value judgment that public health officials and clinicians, and hopefully also well-informed patients, are making, saying that we are willing, even though the risk is relatively high, to take preventive therapy because the risk of adverse events and the downsides of the treatment are low compared to the advantages of taking it. I'm not sure that's always the case. I'm not sure there's always, people are always well-informed, the patients are always well-informed about that. And of course, there's also the public health perspective in that. But yeah, I think that would be my thought on that.
Thank you for the clarification.
The last question.
So Frank, Samuel, thank you for some great presentations and really clarifying the goal of risk of progression. I think one of the important things that I think you've really reinforced today is what we're looking at is really a secondary test beyond a positive test of infection. It's the specificity and sensitivity for progression beyond that initial positive. So from a test manufacturer's perspective, I think one of the burdens you probably didn't highlight, Frank, is the challenge of then not only finding that risk of progression and doing those studies, but also the burden of having an accurate confirmatory test of infection. And there is still no gold standard. And that's a big burden for a test manufacturer to establish that, as well as the risk of progression. So to do those sort of studies, and mirroring some of the industry colleagues, we need funding to support those sort of studies. And it's an area that I think if we all agree and 100% support, this is the test that is needed, but we need to ensure that there's adequate funding to support these sort of studies. So I guess that's the call out. The manufacturers are here to support it. We want to work with you and the biomarker community, but we want to make sure there's adequate funding.
Thank you. Maybe just one quick comment on that. I think you may not necessarily need a good test for infection to do these studies. You could just test somebody that you think is at risk of progressing, and whether that person was infected or not at that point, you would still be able to measure the accuracy of your test, but it would require follow-up, and it would require ascertainment of active TB at the end, and no doubt about it, that will not be a very cheap thing to do, and more funding is absolutely needed for it. So